to ask a question during the Q&A. We decided yesterday that there's way too much to try to fit into an hour. So our colleagues at Person-Centered Universe have said that they'll follow up with a blog post with more examples of maintaining autonomy and preference during COVID-19. And this too, we welcome you to share with your colleagues, friends. All right, so I pass over to the guys to introduce themselves. Thank you.
Thanks, Rahzeb. I just want to say thank you all for taking the time out of your very busy schedules to join us today. We have had such great engagement from our first webinar, and we were very excited, as Rahzeb said, to present yet again today. When we started this webinar, we thought that we would have lots of time and not a whole lot of content, but brevity is none of our strong suits, and we, for those of you who know us, also know that. And so, as Rahzeb said, we're very excited to present on this, but I don't think this will be the end either. So I'm Ashley King. I'm one of the co-founders of Person-Centered Universe, and I am very lucky to be joined by Jim Kinsey and Neal, and I'll allow you both to introduce yourselves.
I'm Neal. I'm the program coordinator at Person-Centered Universe. I've been with Person-Centered Universe for about 3 years now.
Thanks, Rachel. Hi, everybody. I'm Jim Kinsey. I'm Vice President of Engagement Strategies and Continuum of Care Services at Planetree International. I've been with Planetree almost 11 years now, and I'm very happy to have spent the last 4 or 5 years working in collaboration with Person-Centered Universe as a partner in the creation of person-centered environments, particularly for persons living with dementia. So welcome to all of you. It's so nice for me to see a couple of very familiar names on the guest list, and so I'm pleased and happy to reconnect with some of you. Ashley, if we can go to the next slide. So a couple of disclaimers before we start, and what we wanted to make sure that everybody understood from the beginning was that no one on the panel this afternoon is an expert in infectious disease or pandemics. Our comments are based on the current knowledge and recommendations as of today, and I think we all know as we live through this that those recommendations can change on an hourly basis. So the comments are based upon current knowledge and recommendation of the CDC and the World Health Organization as of this afternoon. And then none of our recommendations, whether they come from Planetree or PCU, are meant to override your local regulations and requirements. And that's a real important thing to underscore as we recognize the number of countries represented on the guest list today. So that's just a little bit more housekeeping to go through, and I'm going to turn the beginning part of our program over to Ashley King.
Thank you, Jim. And so first we wanted to take a few minutes to ground you in the philosophy, both that Person-Centered Universe employs in all of our consultation and education work, and as well the philosophies that Jim and his colleagues at Planetree also embody for providing person-centered dementia care. So some of you may recognize this slide and these words, but really we are strong proponents and really allow the work of the late Dr. Tom Kitwood to guide all of what we do when supporting our clients and our friends who are living with dementia. So the late Dr. Tom Kitwood was one of the first individuals to really develop the concept of person-centered care, and in his extensive work in understanding dementia and developing one of his cornerstone programs, Dementia Care Mapping, he identified a number of fundamental psychological and social human needs. So these human needs have been have to be met for all of us in order to maintain a good sense of well-being. And it can really help us to identify and draw out the idea of person-centered care. So these 6 psychological needs, as you see here, are comfort, identity, inclusion, attachment, occupation, and love. So we'll get into a little bit more about each of those components and how they can help you within your organizations and your staff meet the psychological needs of our clients who are living with dementia. So in Kitwood's model, he shows that when we're caring for and supporting people who are living with dementia, we really have to remember these 6 psychological needs, because those of us who are living in the community and not living with dementia have these needs. And just because someone's diagnosed with dementia doesn't mean that they no longer have those needs. So we need to ensure that as we're caring for and providing for the physical body of our clients who are living with dementia, we also need to ensure that we take the time to fulfill these psychological needs of our clients as well, and be very mindful of how we do that. So first we'll look at, in the center, love. And love is really about, it's fundamental, as we all know, because everybody needs to be loved and they need to love someone. Being loved is accepted, and it's part of our need for survival right from the beginning when we were born. And it can range from loving a person, loving a religious or a spiritual belief, or even loving food. Comfort is really about our need to feel warm, dry, clean, have a full stomach, and not feel thirsty. Identity is our need for having a personal identity, from the clothes that we choose to wear, the occupation that we choose to embark in, the food we prefer, and the way we like to do our hair, which I'm sure most of us, the current way that we're doing our hair is not exactly how we'd like it, with no hairstylists around, but usually how we like to do our hair. So all of these, there are many components to our identity that make up who we are and how we engage with the world and how we show ourselves to the world. Then we look at occupation, and we often think, of course, of our jobs, our work that we do, and that is one aspect of it. But all of us want to be occupied with something to feel like we have worth and that we have purpose in life. And just like us, individuals with dementia don't lose that need. So how do we encourage them to be involved in daily activities and meaningful engagement opportunities to support their need for occupation? We also have inclusion, which is about wanting to be a part of something, wanting to feel socially connected and part of a community. And then lastly, we have our attachment, which is really about the connections in life that we have and how they're to our feelings of well-being. So, they have that saying, you're most alike the 5 people you spend the most time with. We all want to feel connected and supported by someone or something. And it's really important for many of us to have a combination of people and communities to help meet that need of attachment. So how do we meet those psychological needs? That's, the thing about meeting the psychological needs is it can be challenging, because those are really high, pie in the sky ideas, and how do we actually meet that? So Dr. Tom Kitwood identified as well, through the implementation of identifying the psychological needs of individuals who are living with dementia. He also identified that individuals need human contact with people that upholds their personhood to thrive. So when I say that, I mean that they they have interactions with individuals, because many of them don't have the capability to continue to maintain their own identities any longer, based on cognitive changes and physical changes, that they really rely heavily on us as care providers and on their families to help them to identify who they are. So our interactions with all of our clients really are focused on how we can help to meet their identity and help to uphold their identity. So we can do that in two different ways. We can do that in a positive way or in a negative way. So malignant social psychology is really about how we can impede the well-being and the needs, the psychological needs of our clients by variably and invariably making them feel like they're not connected to their identity. And we call that, as I said, malignant social psychology. So here are a few ways in which someone could impede on someone's identity by ignoring them, right? One way, one easy low-hanging fruit is by ignoring them. So if we ignore someone or that can add stress, or that can add upset to an individual and strain to that individual by labeling them or ignoring them. And then they lose sight of the fact that they are a person with an identity and they have a unique contribution to their world. So what's more positive and what we like to focus on more is really how we can meet the needs of positive person work. And positive person work is really about not focusing on how we detract someone from having a positive identity and feeling comfortable and safe and inclusive in their communities, but how we continue to maintain those needs and how we continue to maintain their identities. So how do we uphold someone's identity? That can be really challenging. And it seems like a really significant undertaking, really, when really it's about an understanding and an appreciation of the unique needs and the perspectives of each person you come into contact with. Providing positive personhood, it really occurs when a member of staff interacts with a person in a way that has the potential to uphold one or more of his or her psychological needs of comfort. So if we think back to that flower, of comfort, of attachment, of identity, occupation, and inclusion. So collaborating with an individual who's living with dementia, asking them their opinion, supporting them while they choose their clothing for the day, engaging them by inviting them to a socially distanced or physical distance group activity, or validating their needs and allowing them to feel upset or concerned about a certain thing and trying to help them feel better about that are all ways that we can maintain positive personhood and uphold the identity and the well-being of our clients. And so encouraging our clients to better see themselves and recognize themselves and their own unique identities and their own unique contributions by doing these, kind of recognizing, collaborating, having fun and play with them are all ways that you can encourage someone to maintain and uphold their identity through you as the caregiver. And so sustaining personhood and creating a culture of person-centered care, as described by the late Dr. Tom Kitwood, is a standing or a status that is bestowed upon one human being by others in the context of a relationship and social being. It implies recognition, respect, and trust. And I love that quote because it reminds us that at the core of dementia care and quality person-centered dementia care, it's about recognition of the person and their unique contributions and capabilities in our world, that upholding respect and appreciation for the individual living with dementia and building trust to form bonds and relationships are really key to upholding identity. So we talk about the psychological needs, malignant social psychology, and positive personhood work, because those are the foundational guiding beacons of light, if you will. You can use this as the framework to how you'll maintain autonomy and support preference with your clients who are living with dementia. Now, again, brevity is not our strong suit, so this presentation, this is just a very high level summary of how maintaining the psychological needs of someone living with dementia can look. And so what we're going to do now for the rest of the presentation is really dig into practical ways that you can continue to uphold that personhood work, that positive personhood, and how you can mitigate some of the malignant social psychology that can often happen, especially in these times of high stress and high anxiety.
Thanks, Ashley, for that great foundation. And you know, one of the things as we continue to develop content through the last couple of months is this proverb that says, "I am a person through other people. My humanity is tied to yours." And that really began this conversation for me with my colleagues on the panel, but also other colleagues, in terms of how is it then that when a person is living with dementia, the way in which we interact, the way we care with, the way we care for, either enhances their personhood or detracts from it. And you know, this is a conversation that I think is important for all of us to have as we are approaching situations and we are approaching interactions that are not quote unquote normal. And it's important to realize that we are responsible not only for a person living with dementia and their humanity, but we're responsible for each other's humanity. And I had a conversation with a leadership team this morning that was talking to me about how very I-centric staff have become and what are some ways to kind of mitigate that. And one of the things that we talked about was really, how do we open ourselves up to understanding and exploring what's happening in each other's world? And that's really what we're asking folks to do when interacting with persons living with dementia, is to really open yourself up emotionally and be available to experience their world. Ashley, next slide. And so one of the things that we really have to be clear about when dealing with individuals living with dementia, or actually any individual that is ill, is the levels of vulnerability that exist. And I want you to all think about a time where you have been ill and you are not your best self. I know for me, when I am not feeling good, I get banished to our bedroom and I'm told to text if I need anything, because otherwise no one wants to be around me. But that's actually a level of vulnerability, because now I'm not my best self and I am opening up myself to being judged by another person. And if you think about a person that is living with dementia, although we do not label that individual as sick, there are times where they are not their best self. And then the second level of vulnerability is, I'm fearful. I don't know you. I don't know who you are. I don't know how to interact with you. I don't know if I can even, as the third level states, if I can even trust you. And these first three levels of vulnerability exist for every person that is experiencing healthcare or experiencing a situation where they are vulnerable. But then we add a fourth layer of vulnerability for a person living with dementia, and that is they won't remember it later. So whereas for persons that are cognitively intact, I can mitigate those levels of vulnerability. I can understand that they're not their best self. I can empathize with that. I can produce trust. I can ensure that they're not feeling fearful. And I can do that, and that can be sustained. When we are doing our work with persons with dementia, that can't be sustained, because that individual, as you all know, will not remember that. And so we are constantly in this cycle of mitigating these levels of vulnerability with individuals. Ashley? And so as we begin to look at as we begin to look at how these levels of vulnerability and a person's own humanity interacts with the way in which we provide care, it's important to realize that we need to continue to look beyond a person's losses and build upon their strengths and interests within the context of that life history. And one of the things that really occurred to Ashley and Rachel and I as we were developing this content was this idea that we're talking about how to maintain normalcy during a pandemic for a person living with dementia. And the reality is that our biggest responsibility for these individuals is to continue to see the person and to continue to be able to provide whatever stability we have the capability of providing for them. Rachel's going to take us through now a number of ways in which we can access that person's life history and we can begin to build upon those strengths and interests. Rach?
Thanks, Jim. So as you can see here, there's many different ways that we can connect with the person and that we can allow the individual that we're caring for to become a care partner itself. I think a lot of times it can be easy to kind of feel bogged down and feel like you're the caregiver versus care receiver and focus a little bit too much on that. But if we really break it down, we can see that we're partners in care. We ourselves, we're a partner in care, the person who we might be providing care for, their family, the rest of the team, we're all in it together. So we wanted to just kind of outline today a few ways that we can really get to know our care partners and we can really get to know the people that we're caring for. So as you can see, as displayed on the screen here, we have outlined a few different ways. So the first is a life history or narrative that we might refer to it as well. So one thing that's important to remember is that each person that comes to us within our care, they're coming to us with their own unique histories, their own unique set of relationships, life events, their likes, their dislikes, their interests. And there's many different ways that we can use this to help to be able to provide better person-centered care. So we can do this through interviews with the individuals, one-on-one visits that can be certainly very simple to do. Just trying to be able to kind of gain some more knowledge by looking at this life history of the individual that we're talking about, to understand why it is the way they are, who they are when they come to us today, and their likes, their dislikes, anything that can help us to influence their care. So we can do this in a multitude of different ways. One is definitely through our observation. So looking at behavioral responses. How is a person's body language showing how they're reacting to a situation? Do they seem closed off? Do they seem open to something? It's important that we use this as a strength because although somebody who may be living with dementia in the later stages of dementia may not be able to traditionally communicate verbally with us to kind of be able to explain these behavioral responses, they're doing this in a way to show that they have unmet needs. So how can we use our observations to see what they're trying to tell us? And this is another way that we can look at it also, as you can see on the screen here, through their preferences. So how do we be able to kind of see what is it that they like and they dislike? We're not just kind of throwing care at them. How do we let them contribute to their own care and contribute through their preferences? And as you can see at the bottom, we have many partners in care and many resources. Family contributions is one of the biggest ones. As you all know, families are often the biggest advocates for the people that we are caring for and for our clients. And especially in times like these, we know that families are certainly biting at the bit to be able to help out in any way that they can, especially because they may not be able to be physically present during this time. But there's many different ways that we can have family contribute, family and friends, different connections that people have made within the community. These are all different resources that we have to us to be able to find out who this person is and how we can provide personalized care for them. So one example that we wanted to give today in relation to COVID-19 is ways that the family can still be involved. So for example, if we're thinking of somebody who is living with dementia and say they may seem, and for lack of a better word here, agitated or upset, or experiencing sundown behaviors, say around 3 p.m., this might be something that we could mitigate this by, say, having the family video conference in at that time. Potentially, they could be able to offer a bit of advice to the staff, and they can offer a lot of comfort to the families. There's many different ways that we've seen across the board that people are doing this through video conferencing, through phone calls. We've seen it through drive-by window visits as well. So there's many different ways that we can still keep family involved, and we can still be able to have them be partners in care at this time. And as well, team discussion. One thing that we often get bogged down on in care is kind of just focusing on ourselves and on our departments. But it's important to remember that all members of the team, whether it's upper management, whether it's your recreation team, your housekeeping, your dietary team, your LPNs, your resident aides, everybody provides different supports and different knowledge to being able to care for people who are living with dementia and for people who are in our care as well. You may see somebody who is working in your hospitality or in your housekeeping department that may know certain tidbits or facts about the person that they're caring for because they're spending different time with them. They're able to observe different behaviors and observe kind of their idiosyncrasies throughout the day just by having a different relationship with them and having a different connection to them. So really just trying to connect to the person through all these resources that we do have. And we do have some resources that we will share with you in regards to life history and being able to access this and being able to really trying to get to know the person afterward, that we will share in our follow-up email. So this brings us next to the independence equation. So once we've been able to identify all these strengths through looking at their preferences and the life history and our family as a resource, we really want to be able to maintain this independence and maintain these strengths through the care that we're providing and through the activities that we're providing and the different interventions. So as you can see here on this screen, we're really wanting to be able to do different things to support independence and autonomy, which can decrease confusion and frustration, which certainly would be at a high point during this time. You have not as many visitors coming in or any visitors coming in. You may be confused based on the garb that the staff are now wearing, the changes that we're experiencing on a day-to-day basis. And so it's really important to be able to decrease that. And so therefore that leads to an increase in the quality of life. And then of course, an increase in the self-esteem and personhood. And so we're just going to move on here. And we want to look at kind of ways that we can do this, especially in the face of COVID-19 and how we can maintain this independence. And so we'll look at some more specifics here coming up.
So much of this is really fundamental to dementia care in everyday living, and it becomes even more important as we are facing consistently evolving challenges and changes to what quote unquote is the norm. I think one of the things that is important for us to consider is the role that we have in creating routine. And, you know, this routine should be their normal routine, not a routine in response to the external environment. And what I mean about that is that a person living with dementia doesn't have the capacity to process something that we're all talking about, and that is the new normal. Our new normal is not something that a person in moderate to I'm sorry, lost my train of thought. A person living with dementia in the later stages can really process. That idea of a new normal is not something that really exists for that person cognitively. And so we really need to be looking at maintaining their routine to the extent that is possible. And that means then that we focus on what the individual can do. When you look at the independence equation and you look at how that autonomy leads to so many positive things, we really need to be looking at how the person can do what they can do. And you know, I always talk about in my education and training of teams is that idea that if the only piece that I can do is maybe to button my shirt, then my shirt needs to be buttoned by me every day consistently. And that the focus should not be if I have all of the buttons properly lined up. The focus should be that I accomplish the task. And so we need to make sure that that routine is essential. And there are changes to the routine that we know are taking place. We have to try to, you know, we're doing our best to socially distance in environments, and we're doing our best to maintain infection control. And so all of these things are external that are causing routine disruption. And so our responsibility then is to address their routine as much as possible, but also be aware of stress transference. In stressful situations, our stress is easily transferred to the individual. And so we may be feeling an awful lot of stress related to the pandemic. We may be feeling a lot of pressure related to the pandemic, and we may not be even processing all of the information ourselves in a very effective way. That stress can be transferred. But what happens is if I'm transferring that stress just to perhaps maybe Ashley can begin to process that, and she can begin to take that apart and realize that, you know, we're in this kind of relationship of being in this together, and, you know, Jim's really worried about X, and, you know, that's really not a worry for me. It is that process of being able to unpack all of that a person living with dementia has the inability to do. And so, you know, if we are transferring stress that is not able to be processed, we are opening up the risk of a behavioral response and then initiating a cycle of interventions. Again, making that person be the problem, not the actual stress being the problem. So we really want to be mindful of how we are dealing with stress in the environments that we're working within, and that's inclusive of being a family caregiver at home. How are we processing stress, and how are we eliminating as much as possible as we possibly can do? And then that consistency in caregiving that we've all been striving for decades now, but it becomes a pattern of encounter so that the same caregivers are involved with the same individual to the highest extent possible. And when looking at COVID-19 plans, particularly in congregate living settings, you know, if we have to isolate a certain section or area of the building, how do we make sure that that team is composed of people that can consistently be there? Because that is going to be important not only for care, but it is also going to be important to decreasing exposure. And I've been working a lot with many of our long-term care members in developing ways in which we can create consistency while still reducing risk to staff, but more importantly, working with many folks in how are we reducing stress within the environment, and how are we emotionally supporting our staff while at the same time not creating a stressful environment. And some of the things that folks are doing are as simple as making sure that the television news is not on constant play. making sure that conversations are around everyday events and everyday activities as opposed to what people are worried about. But the importance of not asking staff just to not talk about those things, but also providing a forum within the organization where they can talk about those things. So whereas I have teams that when they're working with their residents or their client base, they're not actively engaged in conversations about what's stressing them out in their personal lives, because we've made a space for them, a forum for them to come together as a team to talk about those things and to process those things without engaging residents in those conversations. Next slide, Ash. So one of the things that can happen under the stress of a pandemic is we being caregivers, can sometimes forget everything that we know. And I mean that with all due respect, but there is this internalization of stress and worry that sometimes makes us, not as mindful as we once were or we could be. And some of the things that are really helpful to remind folks of in terms of communication is to really be clear about avoiding elder speak. We don't want to add to, infantizing our conversation. We don't want to, go to overly directive or overly nurturing conversations or direction. And we certainly don't want to have that excessive use of the third person. Making sure that we're supporting clear and concise messages. Plan ahead for what you're going to say, but also be flexible to pivot in the moment and not to become stressed when we do have to have that pivot in the moment. Always aware of body language, tone, and volume, but more importantly now, as Rachel referenced earlier, we need to recognize how the person may hear or see us when we are using PPE. Now, I can remember when I taught nursing assistants early in my career, and we always talked about, how to approach a person with dementia and how to approach a person with macular degeneration and how to approach a person that has a hearing concern. All of those things remain relevant, but what does it mean when I can't process that big yellow blob that's coming into the room? And I don't mean that, disrespectfully, but if you look at a person in PPE through the lens of a person living with dementia, it can be very, very frightening, because everything that we have to use to communicate, except for our eyes, everything that we use to communicate is covered in one way or another. And so how the person recognizes us, how the person hears us, how the person sees us is really imperative in making sure that communication is inclusive and communication is effective. Next slide. And then supporting physical health and independence in ADLs. One of the things that Ashley and I wrote about in a blog post was just the concept of hand washing and how frequently we have to help and assist people with hand washing, and really making sure that we're doing it in a way in which can be therapeutic while at the same time hygienic, and really looking at ways that we meet the person where they are at, providing the encouragement, providing the modeling, providing those clear, concise directions, and also ensuring that things are recognizable in the environment. Is a soap dispenser clearly marked, but is a soap dispenser recognizable? This is something that, we've done a lot of work on environments of aging, and for persons living with dementia, we need to make sure that when we are moving to things that are more visible in a home setting, that they are still recognizable. Do we need to add the additional pictures? Do we need to add additional labeling? And ensuring that everything is in a setting that is familiar for the individual, but really making sure that we're focusing on the physical support in a methodology and in a way that is supportive, but also in a way that is making sure that we're decreasing the infection and that we're decreasing the opportunity for infection, that we're increasing infection control, and that we're ensuring that everyone is safe. And one of the groups that I work with has really begun looking at how do we make physical health and infection control part of who we are and what we do on a regular basis. And, you know, some folks have gotten very creative with, you know, before meal hand massages, which are also adding to, you know, clean hands before a meal. They've gotten very good at, you know, ensuring that what becomes part of the routine is consistent oral care and consistent hand washing. And how do we continue to encourage a person to really be taking care of themselves as we go through this time? Ultimately, when it comes to supporting physical health and ADLs, it is a process of, I need to do what I can do for myself. I need to be able to be actively engaged and actively involved in the care of myself. And again, encouraging people to understand that it's not always about how we would define a positive outcome, but it is about how the person experiences the doing so that their personhood remains intact. Ashley, I think you're up.
Just have to unmute myself there. And that's it. Really, how do we encourage people to maintain their independence? Because again, when we're thinking about independence and activities of daily living, we're recognizing that we play a key role in maintaining that identity for the older adults who are living in our organizations. And so Jim has highlighted a number of different ways that we can help to support and maintain independence. And we're going to drill it down just a little bit deeper into some practical ways that we can employ those strategies today. So you can go out and apply those starting right now. So when we encourage independence with activities of daily living, as Jim said about buttoning the shirt, it really allows individuals to not only feel independence, but it's really meeting those psychosocial needs and the psychological needs that we looked at the very beginning. We're able to really meet the needs of attachment by connecting the caregiver and the care receiver as care partners together, working together. We're able to maintain occupation by allowing someone and encouraging someone to still do those things that they like to do and they feel confident and comfortable in doing for themselves. And of course, it maintains identity. So we need to, as Jim has said, encourage someone, any of our clients, to do as much for themselves as they feel comfortable to do. What can be challenging in those situations, though, is how do we mitigate when someone can't do something? It's easy when we can say, okay, Bob was able to button up his shirt yesterday. Have at her, Bob, it's up to you. But then Bob, for whatever reason that day, maybe he had a really hard night's sleep or he hasn't had his coffee yet, because I know I would have some trouble if I didn't have my coffee in the morning. But he's not as able on day 2 to be able to do what he had been able to do yesterday. So how can you mitigate frustrations and anxiousness based on providing independence and supporting independence for someone? So things that you can watch for and things that you can encourage your staff to watch for are facial expressions and expressions of needing help. Those are universal And the more you get to know a person and understand the nuances of their character and their individuality, and I would seek to believe that many of the care providers in our organizations already have an idea of those things. They just maybe need the support and the reinforcement that those are important. But facial grimacing, getting upset, like getting angry, not being able to do something that you're supposed to be doing, becoming agitated or not communicating the way that they're usually communicating, saying words like, oh, I can't do this. Those are ways that you can mitigate any frustrations that might happen when you're trying to encourage independence. And as I said a few minutes ago, really taking an individualistic approach to this. So how I might identify my frustrations may look very different to how Jim would identify his frustrations. So I might yell out in anger and become, lash out at somebody, but somebody else may not do that. So taking the time to really be a bit of an investigator, to understand how someone operates and how they interact, is really key in being able to mitigate the autonomy while still supporting someone when they need the help. The other thing for us to think of in providing supportive care, for so many of us, the mealtime experience right now, for so many of our clients, but also ourselves, the mealtime experience is really the most enjoyable experience of the day. We're not having our group activities like we once were. We're not as interactive as we once were able to. Our families aren't coming. So we're not able to kind of have that social stimulation and engagement in the same way that we once were. So right now, through the face of COVID, how do we support that mealtime experience, and how do we continue to encourage it for it to be one of the most enjoyable experiences of the day? Something that we'll share with this, as Rahzeb said, we'll share a number of resources because we don't have enough time to talk about everything, but Jim and his team at Planetree have created an incredible document on dining experience. So we'll be sure to share that along. And what are people's preferences when it comes to the mealtime experience? Some of us, like me, we eat because we have to sometimes. Some days I'll be standing at the counter and I will be eating a sandwich. So eating alone sometimes is preferable for me. For other people, having that large communal dining experience that engages and is socially inviting and upholding is really important for them. So how do we mitigate that based on the preferences and the needs of the client and the individual who's living with dementia? We also have to think through the mealtime experience that in the organization that I'm working in right now, we're currently physical distancing. So at meal times. So everyone is spread 6 feet apart during each meal. So how do we maintain that community and those relationships that we would have already been cultivating within long-term care, within our organizations? And how do we maintain those, and how do we continue to support those in knowing that we're living through the new normal? And lastly, how do we provide opportunities for autonomy through care? So maintaining personal preference, like letting your client or the individual choose what they want to wear that day. We have this great picture here that helps for individuals who are living with dementia to be prompted in utilizing their makeup and putting on their makeup by themselves each day. Utilizing ways to communicate, utilizing hand over hand, demonstrating for them can really help for someone to have their own autonomy and do as much for themselves as possible. And sometimes if you need to use signage, that's one thing that we often see is easily overlooked and is a great way to support someone who's living with dementia, is using signage to communicate. Keep it brief, keep it clear and concise in messaging. And in this situation, visuals are really helpful as well. Utilizing that signage to continue is a great way to continue to maintain autonomy through the care experience. And so we just want to loop you back to how we can support the psychosocial well-being to uphold any individual's identity. So again, we just want to remind you that right now and in general, through COVID or not through COVID, the reliance of individuals who are living with dementia on their care providers and their care teams, their families, their friends, to maintain their identity is really significant and it's important. And so allowing us to first take that in and, you know, think about how we can mitigate any malignant social psychology and continue to promote positive person work through our interactions with our clients will be very key in providing good person-centered dementia care. And it'll also help us to really identify and meet the needs of our clients who are living with dementia, because we have the capability to meet those psychological needs of our clients. And how we interact with our clients, that ultimately impacts both positively or negatively their identities. So how can we focus on positive person work as much as possible to maintain identity? And then it's important for us when supporting the psychosocial well-being as well to really get creative in how we connect with community. As Rachel said, connecting with family members in a variety of ways is key, and it's so important. So how can we continue to support and maintain community connection through the absence of the capability to be physically in a community? And then lastly, really meaningful engagement to mitigate boredom and loneliness is so important, and it's so impactful. So finding creative ways, there's lots of, we'll share this in a blog post, there's lots of different ways to engage meaningfully with your clients who are living with dementia.
So one of the things that a lot of folks are talking about is how are we going to maintain autonomy while mitigating risk? And I think, you know, this is a conversation that I know many of us have had for years, but we need to still, in this time, really talk about the conversation around risk and what is the definition of risk for the organization. What is the definition of risk for the person, for the personal risk? And so, you know, we may be saying that we can keep an organization safe if we do X, but what's the impact on the personhood of the individual that is experiencing whatever X is? And the other piece about risk right now is really managing the variances in our in risk response. And what I mean by that is that there has, for many states in the US, particularly in New York and Connecticut, there's been kind of a regrouping that's gone and taken place in terms of some of the restrictions that were put into play at the beginning of the pandemic. And you know, although we've not changed visitation in long-term care currently, but the Hospital Association of New York revised their recommendations around restricted visitation in hospitals because what they realized was that they, you know, and this is not about being right or wrong, but at the beginning of the pandemic, they swung the pendulum all the way over. Nobody could come in. There were, women leaving the state and crossing borders so that their partners could be in the delivery room with them. And, we've all seen the end of life crisis that's been on television. And what New York State came to realize was that the negative impact that risk response was having was now far greater than the impact of spread. And so, when we are dealing with risk mitigation, we really need to be looking at, the evolution of that, if you will. And so where we may have been very, very restrictive at one point, how does that evolve over time so that that restriction isn't always where we go? And even in this very stressful time, we really need to be looking at how do we maintain that autonomy? How do we continue to have individuals defining their lives and defining the way that they live and defining what their quality of life is? So I think we're going to open to questions right now, I believe.
Thanks so much. Thank you, everyone. We're on the hour, so we've packed in lots of information, lots of knowledge. I found it really fantastic, very grounding, wonderful to just be reminded of maintaining our perspective and not forgetting everything that we already know, and the importance of continuity, consistency, knowing the person, understanding their routine, doing all you can to maintain perspective and preference, and recognizing that what you do has a strong influence on how well that can be executed. I suspect that we've kind of filled lots of people's hearts and minds, and there won't be many questions coming through. If there are, we'll answer afterwards. I can see that people start to drop off as usual, on the hour. Jim, Rachel, Ashley, thank you. I look forward to receiving also the blog post and the resource on mealtime experience. Fantastic. And really filling all the framework that you've explained today, filling that next step, which is the tactics, the actions that underlie delivering on this set of ideas that you've communicated. Thanks so much. I've just a comment from Cindy to everyone. Would you like to open your mic, Cindy, or shall I read it out? Do you have a preference?
Mute. Okay, can you hear me?
I hear you, yeah.
Awesome, well done everybody. Thank you very much. That was really, I think we needed to hear it, because I think we needed to be inspired after many weeks of planning and praying that our homes remain safe in New Brunswick. What I did find really interesting, because everything that we're being told is we need to do a risk analysis. Before you make a decision, do a risk analysis. If someone's at end of life, what's the risk if we let family members in at the bedside? And, do a risk analysis to see if staff should work or could work in more than one place. It's all around this risk analysis. And what's interesting, we, all the nursing homes, long-term care organizations in New Brunswick, over the last 3 days have had to meet with government for 2 hours and go through 6 pages of questions around preparation and what have we prepared for this crisis. And one of the interesting things, not that came out in our conversation or our survey yesterday, but there are homes that are being asked to actually start applying restraints on residents with dementia if they become positive. What are you going to do if someone who wanders in and out of rooms, how are you going to actually isolate someone that's positive, that has dementia? and they are wondering, they're not sick, that they're in bed, so they are still up and about. So again, risk analysis. So, what does that look like? And my heart goes out to not only our residents, but the homes that might be forced to do something like that. So just a comment. I don't know if anybody wants to share back their thoughts. I'm watching your eyes when I've mentioned it. So anyway, I just leave that with you.
Yeah, Cindy, I do have a comment, and I think one of the things about risk analysis is that it's so frequently just one-sided, and so yes, there is a risk if a person living with dementia becomes positive, but in a risk analysis that focuses not only on infection control but on the individual personhood, we have to have the capability of identifying other solutions. Does that individual get a staff buddy? Does that individual, do we isolate a particular part of the building where we may actually have more than one person positive for COVID? Do we have a COVID response team so that there are specific staff in specific areas that people can take these individuals to? I think the thing that has been most fearful for me is that we will go back to the way we always responded. Mm-hmm. What is the simple answer to mitigate risk? And I think that we've learned way too much in the decades of person-centered care to go back to that quick response without those of us in the work advocating for not doing that. I mean, there's just way too much evidence on surplus safety. There's way too much evidence on the impacts of personhood. And I think it's through advocacy work that Plaintree does, the Person-Centered Universe does, that all of you do on a daily basis is really where we can begin to start reminding people about what's most important. And that's not to negate the danger of COVID, but we're creative folks. We've come a long way. There have to be other answers.
And Jim, because our organization, not only in your head but your heart, when we started realizing, because we have 2 homes, and I know Becky asked about isolation in a secure unit, we've actually developed 2 COVID units. So in each of our homes, we have a secure area, and I know we had lots of conversation around what we call Cedar House, which is our secure house for 25 clients with dementia that are up and moving. And how the atriums were, Jim, in those 2 houses, Dogwood and Cedar, is, looking at, do we actually use the atrium if we get several cases within that house, right? So how can we, make sure that the others are safe? But we're not naive enough to realize that if you've got residents wondering and you have more than, a few positive, the chances are that house is going to become an isolation house. And we're staff, we've been lucky enough to have 25 staff step up to say they would work in the COVID units. So again, making sure that people are familiar, that the residents know those staff. So, I mean, you're right, you got to be creative. And you've got to, I agree, not resort back to how we used to do long-term care. But it is interesting listening to the experts around, what type of medications and what are you going to use and how much and for who. And so I mean, my heart goes out to a lot of you in the States, because knock on wood, if I can find a real piece of wood around here, that we are keeping it out. In New Brunswick, I think, has been very fortunate that we started early and we started restrictions early, which was not nice for any of us. But anyway.
Absolutely.
Thanks, Jim.
Thank you,
Cindy.
Oh, look.
Yeah, indeed. Becky had a very similar question. Also asking if you have any suggestions. I think it's a good topic to come back to, because it's certainly going to be a recurring theme. I've heard the same conversations also happening here.
Yeah.
It's a really common issue.
Exactly. And I think with it, I think much like all dementia care, person-centered dementia care, there's no silver bullet. It would be a lot easier if there were one, but it's more so about what are the, when we look at it from a risk perspective, as Daphne noted in the chat, she's my co-founder, and she had identified that there's many risks to using restraints as well, whether it's chemical or physical. So what we kind of see, or what we've discussed, is what are the arsenal of supplies that one would need to support someone who is positively diagnosed with both dementia and COVID. And we've kind of discussed a number of different opportunities, whether it's a unit, whether it's a buddy who's mitigating those issues. And I think the other thing that's really very important is engaging families and other care partners, whether it be friends or colleagues, previous colleagues, in finding opportunities for meaningful engagement. It was done very collaboratively in the US with the reduction of antipsychotic use by mitigating decreases in antipsychotics by implementing meaningful engagement opportunities and meaningful recreation. And I think that's something, another spoke in an intricate wheel of how we can support our clients well and safely while still maintaining their personhood and their maintaining person-centered dementia care.
Mm-hmm. Becky says, good point. Okay. If there aren't any more questions coming through the chat, I suggest that we close the session for the day. Thank you, everyone. It's a great session, really very, grounding is the word that comes to my mind. Yeah. Okay.
Thank you. Thanks so much, everyone, for taking the time today.
Thank you all. Be well.
Yes. Good day. Bye-bye.
Bye.
Yeah.
Bye-bye.